When it comes to the etiological activity, if there is osmotic diarrhea, that means there has to be osmotically active particle in the bowel that drains a lot of fluid into the bowel lumen, so the patient would have large volume diarrhea. Usually settles when the patient is fasting, because most of the time osmotic diarrhea is due to some osmotically.
So can you record the lecture?
Yeah, sure. So most of the situations, these osmotic diarrhea would has to settle when you are fasting. So that's the pattern. So as I said you previously, 80% of the time, majority of the patients, when you go through the history, diagnosis is evident. So if somebody comes to you complaining of large volume watery diarrhea, that usually settles when the patient is fasting, that indicates an underlying osmotic barrier. Then, depending on the subsequent history and the physical examination and maybe some investigations, you have to decide what is the cause of this osmotic diarrhea is. Then, steatorrhea or fatty diarrhea. Most of those patients with the steatorrhea or fatty diarrhea have again large volume diarrhea. They have very bulky stools, which are usually difficult to flush. Very bulky stools, difficult to flush, oily. And when it comes to the definition, steatorrhea indicates that there is more than 6 grams of fat excretion over a 1-day period or a 24-hour period. So certain malabsorption syndromes, like mucosal diseases, small bowel bacterial overgrowth, mesenteric ischemia, they can have fatty diarrhea or steatorrhea. And not only the absorption problems, sometimes the digestion problems, like in the case of exocrine pancreatic failure in patients with chronic pancreatitis, and inadequate luminal bile acid, again, they present with steatorrhea. So the hallmark of the steatorrhea is deficient or insufficient fat absorption in the bowel. Then there is another category called inflammatory diarrhea. Inflammatory. So the underlying inflammation could be due to an infection, underlying infection, or things like inflammatory bowel disease where there is no existing infection but there is extensive inflammation of the bowel. So when it comes to infections causing inflammatory diarrhea, things like tuberculosis, pseudomembranous colitis caused by Clostridium difficile or C. diff, then Yersiniosis. Not only these parasites and bacteria, sometimes viruses also can cause chronic diarrhea, things like CMV, cytomegalovirus. You might see patients presenting with chronic diarrhea. Then patients with ischemic colitis, radiation, in colonic CES and lymphomas, they have inflammatory diarrheas where there is some inflammation or inflammatory cell infiltrate into the bowel wall. Then there is an entity called secretory diarrhea. Again, patients present with large volume watery stools. And the hallmark of secretory diarrhea is they don't settle with fasting, like in the case of osmotic diarrhea. Because in the osmotic diarrhea, the hallmark is they settle with fasting. Secretory diarrhea, the hallmark is again large volume watery diarrhea that do not settle while the patient is fasting. So the patient may go on to have nocturnal episodes of diarrhea. Patient may be woken up with the sleep with episodes of diarrhea. So classical examples would be laxative abuse following cholecystectomy, then vasculitis, then autonomic neuropathies due to increased sympathetic activation or sympathetic activation, they may go and have secretory diarrhea. Then some neuroendocrine tumors like gastrinomas, VIPomas. What is VIPoma? What is VIP? Yeah, VIP. What does it stand for? What the VIP? Anyone?
Selective inhibitory peptide.
What's that? Receptive inhibitory peptide. Okay. Anyone else? මොකද VIPomas කියලා කියන්නේ? What do you mean by VIPoma?
I'm not sure.
What?
I'm not sure, sir.
Okay. So who told this? Actually, inhibitory peptide?
It's a pancreatic tumor.
Yeah, so the tumor can occur somewhere in the bowel or even in the pancreas. But VIPoma stands for actually vasoactive, not inhibitory, basically vasoactive intestinal polypeptide or vasoactive intestinal peptide omas. So that's one of the secretory tumors that can occur in the gastrointestinal tract. Maybe in the pancreas, sometimes maybe somewhere in the bowel. So that's what actually VIPoma stands for. Again, it's a bit of a rare kind of a tumor in the GI tract, but you may see once in a blue moon, you may see one patient. So they present again with large volume watery diarrhea. There's a lot of secretions being produced by those tumors. Then in conditions like carcinoid syndrome, where they have episodes of asthma and diarrhea. Asthma and diarrhea. So that's a characteristic clinical presentation of patients with carcinoid. Again, they have a lot of GI secretions. Even with fasting, they present with diarrhea. Then villus adenomas. That's fairly little bit of a common type of villus adenoma. They present with again secret diarrhea and sometimes muscle weakness due to hypokalemia. So that's the hallmark of secret diarrhea. You can go on to the causes later on, but main thing is history and mainly history. Large volume watery diarrhea that does not settle even with fasting. Go on to have diarrhea even with fasting. Then you may come across some patients with drug-induced diarrhea. Drug-induced. There are lots of drugs that can cause diarrhea, things like laxatives, isn't it? Can cause some people actually abuses laxatives. When they initially get constipated, they go on to take laxatives and develop diarrhea. Sometimes drugs like metformin, so common drugs like metformin also can cause some diarrhea. Then proton pump inhibitors and antacids, mainly magnesium containing antacids. So aluminium containing antacids usually cause some constipation. Magnesium being one of those molecular particles causes diarrhea. So in the history, one of the important things you have to inquire is the drug history, whether the patient is taking any drugs that may precipitate diarrhea. Then commonly the antibiotics, any antibiotic can cause antibiotic-associated diarrhea. But commonly the cephalosporins, clindamycin, amoxicillin, co-amoxicillin, all those drugs can precipitate diarrhea. You also may have had some antibiotic-induced diarrhea. Have any one of you had any antibiotic-induced diarrhea? And some of those who had any antibiotic-induced diarrhea in the past? No one seems to have. So that's good. So you may have not taken any antibiotics. Okay. So sometimes antibiotic-induced diarrhea can be a benign. It settles on its own sometimes even if you go to take antibiotic. But only problem is you have to differentiate when somebody develops pseudomembranous colitis or C. diff diarrhea. It's a little bit of a difficult situation with antibiotics. C. diff predominates, so you develop an invasive colitis with the blood and mucus diarrhea. So in that case, you have to stop the antibiotic. Stop the antibiotic and see. Usually with the more common benign forms of antibiotic induced diarrhea, patient won't deteriorate, like in the case of pseudomembranous colitis or C. diff. But if you have a doubt, there is a gold standard test to differentiate. So that would be what is the test to differentiate? If you have a doubt if somebody is having antibiotic-induced diarrhea or a pseudomembranous colitis or C. diff diarrhea, where you have to stop the antibiotic urgently. If you are in a doubt, is there any test to differentiate? Doubt එකක් තියෙනවා නම් මේක මේ antibiotic එකක් කරන් ආපු නිකන් diarrhea එකක් නැත්නම් C. diff diarrhea එකක්ද කියලා කොහොමද differentiate කරන්නේ? You have to initially go through a careful history if the patient is ill, having blood and mucus in stools, and there is abdominal tenderness, colon tenderness, then actually you can suspect clinically. But if you are in a doubt, even after the history and examination, if you are given a chance to do a single test, what the test you would do to decide to stop the antibiotic, and very likely that patient is having pseudomembranous colitis.
Colonoscopy.
Colonoscopy. Colonoscopy, you may get some clue, but is there any non-invasive test?
Detection of Clostridium difficile toxin
Where?
in stools.
Good. Yeah. Yeah, I agree. So good. So that's the answer. If you're in a real doubt and you are in an ideal world, then you can do stools for C. diff toxin. The C. diff toxin is detected in the stools that indicates C. diff diarrhea rather than just a benign antibiotic-induced diarrhea. So you have to stop the antibiotic urgently. But it doesn't mean in all the cases of antibiotic-induced diarrhea, if you give some antibiotic for a respiratory infection or if the patient develops some diarrhea, that doesn't mean you will jump and stop the antibiotic. But if there's a suspicion about C. diff diarrhea, we have to stop. Unless you stop the antibiotic, patient will deteriorate with that condition. Fine. So a lot of drugs are there that can precipitate diarrhea. So one of the things you have to keep in mind, whether I am dealing with the iatrogenic diarrhea. So as I have said you before, etiologically, mainly infections predominate in developing world, and in developed countries, mainly the non-infectious causes, mainly the inflammatory and functional causes may predominate. Fine. So when it comes to the clinical evaluation, as we have discussed before, history is the main component. You have to analyze the presenting complaint in detail. First thing, of course, to verify whether are you dealing with the diarrhea or not first. Then whether it's a chronic one, depending on the timeline of the presenting complaint. And you have to inquire into the details of the frequency, volume, and the consistency of stools. Whether it's watery, semi-solid, or whether it's containing fat, so greasy, foul smelling, difficult to flush stools, and whether it's blood stained or not. Those are the main things in the initial evaluation you have to concentrate. And as I have said you before, duration of symptoms. If it is more than 4 weeks, yes, that's chronic diarrhea, but how long the patient has had the symptoms, well, how many episodes did the patient has had, whether it's going on for months, years, and apart from blood staining, whether the stool containing mucus or not, and then the color of the stools, whether it's yellowish, greenish, and black stools. So somebody coming to with a tardy that liquid stools, several episodes over the last few months duration, what is the main thing you would suspect? Tardy black liquid stools going on for several months, several episodes.
Colonic carcinoma.
Colonic carcinoma.
Upper G.
Yeah, actually, tardy black liquid stool indicates patient has melena, isn't it? Melena, usually due to an underlying upper GI. There you would suspect whether the patient has
Variceal bleeding.
Good, that's the thing. Variceal bleeding due to underlying portal hypertension. Some cirrhosis may come through with the complaining of diarrhea. But when you go into the details of the history, patient has tardy black liquid stools that indicates melena. In my way, you have to suspect the commonest cause is cirrhosis. Then, in fact, actually, duodenal and gastric ulcers also may present with that. So the hallmark is upper GI bleeding. Somebody has started that liquid stools. So that's how you have to give detailed attention to the consistency, volume, and frequency of stools. And you have to find out whether there is a diurnal variation, whether the symptoms resolve completely at night or the symptoms continue to occur during the night as well. So if the symptoms continue to occur during the night, that indicates some sinister pathology. Very unlikely to be a functional or irritable bowel syndrome. Most of the functional benign conditions like irritable bowel syndrome, symptoms tend to resolve at night. Very unlikely patient would be woken up at night to pass stools. So that's one of the things you have to inquire into. Then any relationship with the food. If the diarrhea settles with food or aggravates with food, that's one of the things you have to. And whether the diarrhea settles while fasting. As I have said before, if the diarrhea settled while fasting, you are very likely to deal with the osmotic type for diarrhea. Then associated features like abdominal pain, tenesmus. So what do you mean by tenesmus? Tenesmus, the one.
So you feel the urge to pass stool always, but then you don't end up passing.
Yes, good. So a sense of incomplete evacuation of stools, even after passing stools, you haven't really emptied the rectum fully. So sense of incomplete evacuation of stools even after passing. So that's tenesmus. So tenesmus can be there when there's some colitis or some underlying lower GI or lower colonic malignancies, rectal cancer, one of the features will be tenesmus. So those are things, associated things you have to inquire. Then associated constitutional symptoms like loss of appetite, loss of weight, and so on. So that's very important to inquire. Then going beyond the GI system, as I have told before, you have to inquire into details of the other systemic symptoms as well, because that may give you some clue beyond the GI system. Not only the diarrhea related to GI system, you might have to inquire about episodes of dysphagia, oral ulcers, and history of perianal fistulas as well. So going beyond the GI system, when it comes to cardiovascular system, you might have to inquire whether the patient had any shortness of breath on exertion, palpitations. So if somebody has recurrent palpitations and fatigue and going on to have chronic diarrhea, what does that indicate? What might be indicated? What are the things you might be suspected? Somebody having chronic diarrhea, recurrent palpitations and fatigue.
Thyrotoxicosis.
Good. Yeah, maybe thyrotoxicosis. Palpitations and chronic diarrhea, you may be dealing with thyrotoxicosis. Then you might go on and ask you other questions related to thyrotoxicosis, like increased sweating, heat intolerance, loss of weight despite maintaining a good appetite. Those are other questions you are interested to ask, isn't it? So you can direct the history. You can direct the history depending on the initial presenting complaints. Then we'll go to the respiratory system. So not only thyrotoxicosis, but if somebody has palpitation, you might have develop some heart failure secondary to chronic diarrhea, because somebody losing a lot of nutrients in the stools, developing some malabsorption. They may go on to develop heart failure even without that. So you are really interested in some symptoms in this cardiovascular system. Then when you go to respiratory symptoms, whether somebody has chronic cough, recurrent sinopulmonary infections, and history of asthma, recurrent expressions of asthma in the respiratory system, you might be asking in somebody with chronic diarrhea. So for an example, if somebody has chronic recurrent sinopulmonary infections with chronic diarrhea, what does that indicate? What might be indicated? Having a chronic diarrhea with recurrent sinopulmonary infections. Chawla?
Sorry, sir. I didn't get the question because the sound is not heard properly, sir. It's like harshy and
Okay, sorry. So the question is, if somebody has a chronic diarrhea with chronic sinopulmonary infections, recurrent infections, what does that might indicate? Because we are in a systemic review of the history. Under the respiratory system, if you inquire, patient says he has recurrent sinopulmonary infections with a chronic diarrhea. What are the things you might be suspecting, or what detailed other questions you might ask the patient? Anyone?
sir, I'm not sure about the answer.
Malin was trying to say something. So it's really interesting, isn't it?
Can
Why?
be it cystic fibrosis, sir?
Very, very good. Cystic fibrosis. Yeah, that's one of the conditions you may suspect, because you might think, why the hell you are worried about the respiratory system when somebody comes with a chronic diarrhea? But you have to ask. Unless you ask, you can't work it out properly. So if somebody has recurrent sinopulmonary infection with a chronic diarrhea, one of the things you will be aiming at is cystic fibrosis. But good. So that's one of the things I say. So you might be thinking that the patient is having cystic fibrosis. So they develop chronic pancreatitis as well as recurrent sinopulmonary infection. So good. But having said that, cystic fibrosis is one of the rare things in our population. In UK, I have seen many patients with cystic fibrosis, but here, in fact, I have seen only one patient in my life, cystic fibrosis. very rare in our setup. Any other conditions? Chronic diarrhea and recurrent sinopulmonary infections. Anybody with ciliary dyskinesia, primary ciliary dysfunction. So they also, because of the poor ciliary functions, they go on to have recurrent respiratory infections as well as chronic diarrhea. So if somebody has recurrent episodes of asthma with chronic diarrhea, what are the things you might be thinking? Chronic diarrhea with recurrent exacerbations of asthma, difficult to control.
Could be carcinoid syndrome.
Very good. Carcinoid syndrome. That's one of the things you may be suspecting. So sometimes patients may in worry, maybe chronic diarrhea, episodes of diarrhea, but patient may be telling you, doctor, I'm having recurrent episodes of asthma also not seems to be responding to the inhalers. The carcinoid syndrome is one of the things you might suspect. So that's why RS questions are important in patients. The nervous system, can't forget about the nervous system as well. So any symptoms of cranial nerve defect, something like diplopia, nasal regurgitation, nasal voice indicating an underlying palatal or a bulbar palsy, numbness of feet and hands, numbness of extremities, ataxia, blindness, especially nocturnal blindness, and tremors of hand. So if somebody with a chronic diarrhea comes and says, doctor, I'm finding it difficult to see in the dusk and night. My vision seems to be deteriorating mainly in the dusk and the night. So what does that might indicate? What may be the thing that patient trying to tell you? Sashi?
So within A deficiency, would it be night
Yes.
blindness due to that?
Very good. Vitamin A deficiency. Why? Vitamin A causes night blindness. So patient may be becoming blind specifically toward the dusk and night. Developing vitamin A deficiency. So good. Then if somebody complains of tremors, and when you outstretch the patient's hand, you see some coarse tremors. So what does that might indicate? Somebody having tremors with chronic diarrhea.
Thyrotoxicosis.
Good. Yes. Maybe thyrotoxicosis. Why not? So likewise, nervous system. Some questions to inquire nervous system deficiency. So if somebody comes to you with recurrent falls, numbness of extremities, and some ataxia, and patient seems to be having some episodes of diarrhea for months, what is the association you might suspect? Why somebody with a chronic diarrhea might come to you and complain of symptoms of peripheral neuropathy and ataxia and so on?
Can it be Guillain-Barré syndrome due to Campylobacter?
But chronic diarrhea, can somebody go on to have chronic diarrhea? Guillain-Barré, there is some relationship to diarrhea. It's basically post-diarrheal acute inflammatory demyelinating polyradicular neuropathy, or AID. It's a post-infectious syndrome, GBS or AID. But somebody going on to have chronic diarrhea.
Advanced diabetic autonomic neuropathy.
Very good. So, very good. Advanced diabetic autonomic neuropathy. So, this patient may be having some poorly controlled diabetes causing autonomic neuropathy and episodes of diarrhea and peripheral numbness. But good. So, any other? So, that's a common any other thing. So if you do a fasting, that's the first thing I also want to fasting. The fasting blood sugar is normal, and you have ruled out diabetes. So the other thing why fasting, chronic diarrhea, and now having some paper. Could be some vitamin deficiency. Could it be some vitamin deficiency? Something
Vitamin
like
B12.
good, yes. Could be some vitamin B12 deficiency, isn't it? So patient is having chronic diarrhea at the same time, vitamin B12 getting malabsorbed and go on to develop vitamin B12 deficiency. So now the predominant complaint may be numbness of the extremities, ataxia, and when you examine carefully, there may be loss of joint position sensation and vibration. So vitamin B12, so that gives a clue to the specific etiology of the diarrhea as well. Why? You know the place where the vitamin B12 get absorbed in the gut. Where does the vitamin B12 get absorbed?
In the terminal ileum.
The terminal ileum. So you might think whether you are dealing with the problem in the terminal ileum. So likewise, so inquire some of the relevant questions in the nervous system. Then when it comes to musculoskeletal system, bone pains, proximal muscle weakness, patient may be complaining that doctor, I am finding it difficult to squat up from a seated position, and I am finding it difficult to comb my hair and lift my arms above the shoulders. Some proximal muscle weakness and bone pains. So what does that indicate? Somebody with a chronic diarrhea finding it difficult to squat up. What is the relationship? What is
vitamin D deficiency causing osteomalacia?
Yes. Yeah. That's the thing. That's the thing I would be worried about in an adult. In Malaysia, in a child, it's triggers due to malabsorption of vitamin D. So that's the thing you would be suspecting. So if somebody complaining of large joint arthritis related to musculoskeletal injury, large joint arthritis with some pain in the spine, and seems to be having an ongoing diarrhea for months. So what are the things you would suspect?
Enteropathic arthritis.
Good. Enteropathic arthritis due to
ulcerative colitis.
Colitis.
due to the inflammatory diseases, either ulcerative colitis or Crohn's. Enteropathic arthritis. Then, after the analysis of the presenting complaint and history, you would detail systemic review, go on to the past medical history. There you would be interested to know whether the patient has seen episodes in the past, then whether the patient has any medical illnesses like diabetes, thyrotoxicosis, and whether the patient had any history of malignancies, history of tuberculosis, HIV, and whether there was any previous treatment with radiotherapy or chemotherapy. So those are things you might be asking in the past medical history. In the past surgical history, whether the patient had any previous bowel operations made, or whether there was a history of polycystectomy. Somebody had a polycystectomy. They have a poor reservoir of storage of bile acids. So bile acids flow without control into the bowel fluid. So bile acids may not get absorbed, do not get absorbed because it flows very fast into the bowel, unlike in a patient who has alcohol bladder. So due to poor bile acid reabsorption, patient develops diarrhea following cholecystectomy. Most of those patients settle after some time, but you will treat with the bile acid resolving substance like cholesterol. give some symptomatic relief for the diarrhea. So if somebody with a past history of polycysticectomy comes to the department with the diarrhea, you might have to suspect of bile acid diarrhea. So then the drug history, as I have said before. If any allergies, food intolerances like lactose intolerance, you might have to inquire. But mainly the teenagers and childhood develop lactose intolerance. Then the family history of any GI disorders, history of bowel malignancies. Then mainly the social history. At last, social history, but not least, whether the patient had any psychosocial stress related to diarrhea. And sometimes some of the diarrhea may be precipitated by psychosocial stress, like in the case of irritable bowel syndrome. When you are getting an exam, the moment you eat, you might need to go to the toilet to pass stools due to overactivation of gastrocolic reflex. It's precipitated by stress. Sometimes stress might precipitate diarrhea, and other way around also true. Diarrhea may produce some degree of psychosocial stress to anyone. Then the patient's occupation, high-risk behavior, and travel history you are quite interested to know. And you have to obtain patients' concerns and wishes, and you might ask patients' first perception or also regarding the diarrhea. You might ask the patient, what do you think the most likely cause of diarrhea is on the patient also. Sometimes patient may be having different ideas. So when you get those components on the history, 80% of the time you are in the diagnosis. So after this history, only you move on to some of the examinations. So there are things in the general examination you have to examine the patient for. Somebody with a chronic diarrhea. So general appearance of the patient is a thin build, emaciated. So if somebody is emaciated and thin build, that indicates there is some organic pathology. Very unlikely patient comes to you with the functional pathology. Somebody is emaciated always. The patient is averagely built or obese, you may be thinking of some other etiologies. Then in the face, there are certain things you have to examine. So what are the things you might see in the face, somebody with a chronic diarrhea? What are the things you are interested to examine or see in the face? Face එකේ බලන්න පුළුවන්.
Features of chronic malnutrition.
Yes, these are chronic viruses. So what are those?
Angular stomatitis, cheiliosis, glossitis for vitamin deficiency, for peripheral stigmata, vitamin deficiencies.
Good. Yes. Peripheral stigmata of any vitamin deficiency. Angular stomatitis, glossitis, cheilitis might indicate some underlying malnutrition, especially vitamin B12, B1 deficiencies, iron deficiencies might cause glossitis. Then angular stomatitis again due to vitamin B1, B2 deficiency. Then anything else in the face apart from signs or features of vitamin deficiency like glossitis, angular stomatitis, anything else in the face?
Hello?
Dehydrated symptoms.
Hello?
Yeah, very good. Hello, yes. What was the other thing you mentioned?
Dehydrated symptoms.
Yeah, whether the patient is dehydrated or not, isn't it? Whether the mucous membranes are dry, patient may be dehydrated with the diarrhea. Good. Pallo, why not? Yes, pallo. Whether the patient is having pallo, that indicates underlying anemia, isn't it? Just give me 1 second. I'm just getting cold. So think what are the other things that you might see in the face?
So is it possible to see edema-like things because hypoalbuminemia?
Yes, edema is correct. Sometimes you might see some facial edema due to hypoalbuminemia. Some patients may be losing a lot of albumin in their stool, so patient may be hypoalbumic. You may see an edematous face. Yes, why not? So anything else? In the face? If somebody having some jaundice or icterus in the face with a chronic diarrhea, is it something relevant? What may be the underlying cause you might be suspecting? Somebody having a diarrhea, chronic diarrhea, having an icterus or jaundice, sclera. What is the relationship? Maybe somebody having a chronic hepatic illness, isn't it? Chronic hepatic illness with a diarrhea. If somebody is doing other thing, somebody may have developed some drug-induced diarrhea and a drug-induced hepatitis. That may be the reason why somebody is jaundice. Or somebody with a malignancy having porta hepatis secondaries causing obstructive jaundice. Chronic malignancy with obstructive jaundice coming with the diarrhea and jaundice. So those are the things that sometimes it may be interested there. In the face, then appearance of the hair also differs in somebody who is malnourished than in a person who is averagely nourished, isn't it? So hair is dry and easily breakable in somebody who has a chronic malnutrition. Then when it comes to hands, what are the things you would see? Hands.
Clubbing,
Yeah, clubbing. What does that indicate?
inflammatory bowel disease,
Yeah, if there's clubbing, it might indicate some inflammatory bowel disease. Anything else in the hands?
Koilonychia.
Good. Koilonychia in patients with iron deficiency anemia. If somebody malabsorbing iron, having a deficiency in iron absorption, conditions like celiac disease, isn't it? There may be some koilonychia. Then leukonychia, can it be possible with somebody having chronic diarrhea? White nails or leukonychia.
Yes, it is possible.
How?
Because if the patient is having chronic diarrhea due to underlying liver disease, like in cirrhosis, so patient can be presented with leukonychia.
Yes, good. If there's an underlying cirrhosis and a chronic diarrhea, yes. But even without an underlying cirrhosis, if somebody is having a protein losing enteropathy with a lot of albumin being lost in the, lot of proteins being lost in the stools, again patient may develop some leukonychia. Then if somebody has warm, moist hands with the chronic diarrhea, what are the things you might suspect?
Hyperthyroidism.
Yes, but warm, moist hands. And if you ask the patient to outstretch the hands, you might see some tremors. So hyperthyroidism. Again, people with carcinoid syndrome also may have some moist, sweaty palms. Then you have to do a detailed inner survey, head to toe, about this appearance of the skin of the person, isn't it? Skin appearance. Starting from the skin color. There may be evidences of underlying vitamin deficiencies in the skin. Then peripheries of the patient. Have a careful look at the periphery. Some patients due to underlying vasculitis may be having some vasculitic ulcers in the toes, tip of the toes and the tip of the fingers. And due to underlying peripheral neuropathy, patient may be having neuropathic ulcers of the extremities. So you would have a careful general look at the patient before jumping to have a system examination. Then go on to examine the cardiovascular system, do a pulse examination, jugular venous pulse waveform as well. So if somebody with a chronic diarrhea has an elevated JVP with a CV wave, what does that indicate? JVP එක elevate වෙලා නම් මොකක්ද හිතෙන්නේ? There may be certain things you are suspecting in that patient. JVP, most of the time with the diarrheal illness or chronic or acute diarrhea, JVP drops, isn't it? Because patients are dehydrated, as one of you correctly mentioned. But if the JVP is elevated, somebody with a chronic diarrhea, you may be suspecting some conditions. What are those? Pneuma. So I did hear that. So yes, if JVP is elevated, sometimes you may be suspecting an underlying right heart failure with a chronic diarrhea. In conditions like carcinoid syndrome, you might see that tricuspid regurgitation with the diarrhea. So JVP, careful, have a careful look. Then blood pressure, most of the time blood pressure tends to be low, isn't it? Sometimes unusually blood pressure can be high as well in conditions like thyrotoxicity, where the pulse pressure is wide with a high systolic blood pressure. And look for cardiac murmurs. If you hear a murmur of tricuspid regurgitation or a tricuspid stenosis, you may be dealing with the carcinoid syndrome. Then auscultate the lung bases to see whether the patient has an underlying heart failure with the diarrhea. Then when it comes to RS, look for underlying pleural effusions, maybe due to hypoalbuminemia or due to an underlying malignancy, sometimes disseminated tuberculosis. Then bronchi, whether there is an element of asthma with chronic diarrhea. Then under the nervous system examination, look for peripheral neuropathy. There I have in the CNS, central nervous system. So under NS, under the nervous system, look for peripheral neuropathy, ataxia, and cranial nerve defects. May be linked with the underlying diarrhea. Then you go to the abdominal examination. Carefully look for a palpable liver, free fluid in the abdomen, splenomegaly, and any colonic tenderness. So only after the history and examination, you get some minute contribution by few targeted investigations. But patients with chronic diarrhea, you are interested to do a stool analysis. There you would look at the pus cells, RBC in stools, whether there's any cysts, parasitic cysts over in the stools. Then sometimes you may be interested to specifically look for certain component excretions in the stools, especially fat excretion. If it is more than 6 grams, as I said before, it indicates underlying fat malabsorption, steatonia. Then the stool volume may be increased and may not be increased as well. Usually in cases where patient has secretory or osmotic barriers, usually stool volumes can be very high, something like many liters. Then significant reduction or decrease in stool volume while fasting indicates an underlying osmotic diarrhea. Then one of the specific tests to differentiate whether there is an osmotic or a secretory diarrhea is the test of stool osmolar gland. you can check the stool osmolar gland where you subtract or reduce stool osmolality. Stool osmolality subtracted by sodium and potassium. Double the sodium and potassium concentration in the osmolating stools. You can calculate the stool osmolar gap. If the stool osmolar gap is less than 50, that makes osmotic diarrhea unlikely. If the stool osmolar gap is more than 125,
Hello? Anybody there? Saman? Hello?
Aman is the host now, ne?
අනේ මේ සර්ට අපු ඉලෙක්ට්‍රිසිටි ගියා ඇතිනේ සර්ට කිය අනේ සමන් කියන්න දැන් කොහොමද 10ට ලෙක්චර් එකක් කියලා
මම සර් මම කිව්ව 10ට ලෙක්චර් තියෙයි කියලා.
කියලා හරි හරි
ඊට කලින් ඉවර ගන්න පුළුවන්.
ඒක තමයි එකපාරට ෆාස්ට් යන්න ගත්තේ ලයිට් ගිහිල්ලාද කොහෙද ගාල්ලේ කටි දනුක ලයිට් ගිහිල්ලාද
ලෙක්චර්ස් ඉවරක් දන්නේ නැහැ.
තමයි මම හිතන්නේ ලයිට් ගියා සර් එහෙම ඩිස්කනෙක්ට් වෙන්නේ එහෙම සාමාන්‍ය ලයිට් ගියාම